to today's good afternoon, everyone, and welcome to today's COE session. Today is the 9th capacity building session for the 3 medical colleges of Haryana and 9 districts of Delhi, and all others are welcome to join. So a very warm welcome again. The objective of these sessions is to support our sports for better management of tuberculosis and DRTB. Today we have Dr. Upasna with us. Dr. Upasna, she is from our institute and she is the head of internal medicine. She is also in charge of the ART center at NITRD. She is also the HIV/TB expert in the technical research group of NACO. She also heads and she's the technical lead for the e-Nishchit eco that we do from our institute, which is done twice a month. And for our introductions, I am Dr. Neeta Singla, and I head the Department of Training here, and I'm the in charge for the COE activities at NITRD. On my right is Dr. Rupak Singla, who is the consultant in the Department of TB and Chest. Over to you, Dr. Upasna, for your talk.
Ma'am, thank you very much for your kind introduction. Ma'am, screen sharing has been disabled by host.
It's enabled now.
Okay, thank you, ma'am. So, a very good afternoon to all our participants who are joining us from Haryana and Delhi. Am I audible?
Yeah, Dr. Upasna, you're very clear.
Yeah, so thank you very much. And today we will talk about HIV/TB. When we start talking about HIV/TB, there are lots of aspects of HIV and TB which we could talk about, but today we are restricting the talk to the guidelines. So I'll begin my talk with a little introduction about the burden of the disease. Well, if we have to understand the burden of HIV-associated TB, the best thing to understand here is not the actual numbers, but it would be good to understand that HIV people who have active TB, new cases of TB, they comprise only 8.2% of all the new TB cases in the world. But when you look at the TB deaths, it comprises 21% of TB deaths in the world. So something that comprises only 8.2% of a problem is actually contributing to 21% of the mortality burden. So this is where the problem gets highlighted. If we look at India, the prevalence of TB and HIV positives is about 5 to 6%. Every year they show a slightly different figure, but it generally moves between 5 and 6%. And every year some years we show 75,000 patients of HIV/TB, some years we show 53,000. So on an average, we have about 75,000 to 1 lakh HIV/TB patients in the country. We have the second highest global burden of HIV/TB, and it again constitutes a big mortality of about 35,000 HIV/TB cases annually. So this slide and the slide prior to this clearly shows that HIV-associated TB is a serious threat to public health, and TB is a major cause of death among people with HIV. And hence the need to talk about HIV/TB when we talk about TB trainings. Because we are a group of people who work mostly in TB, I would like to now present a little bit about the facts about HIV in India. Well, India has the third highest number of estimated people living with HIV. Our current HIV prevalence is 0.22%. Sorry, this is wrong. It's not the 2017 report. It's the report after that, which came in 2021. Out of which nearly 40% are women and 3% are children. Initially, to start with, the HIV epidemic in the country was very, very heterogeneous. There were 6 high burden states, one Maharashtra, Tamil Nadu, Andhra Pradesh, Karnataka, and then we had Manipur and Nagaland in the northeastern states. But over the years, we have seen that the national HIV prevalence has declined. The earlier higher prevalence in the states which I just enumerated is declining. But unfortunately, the previously so-called high burden states, the prevalence has gone down, while there is a rising trend in HIV in moderate to low prevalence states like Chhattisgarh, Gujarat, Jharkhand, Odisha, Delhi, Haryana, Uttar Pradesh, and Uttarakhand. This graph again shows how the HIV epidemic, the prevalence has gone down in the country. When we started in counting, that was in 2007, it was 0.34% of the population, and now it is nearly 20.9%, 0.22%, with around 21 lakh HIV people in the world. Even though we have seen a steady decline in the HIV prevalence, a major dent has not been made when it comes to HIV TB deaths or HIV TB. This is a graph from India where you can see that the death rate in HIV TB people is as high as 36%. In Nizamabad district, it is 28.5%. In Andhra Pradesh, it is more than 10%. So with all the advances or all the benefits that we have had of HIV prevalence going down is not really reflected when we look at the HIV TB scenario of the country. Now, why is HIV and TB important? We have already discussed our epidemiology shows numbers, the Indian epidemiology shows numbers, but then there is also an immunological basis. This is an oversimplified picture of the immunity of a person, what happens when they have both HIV and TB. See, HIV and TB, each disease worsens the other, hence a bidirectional interaction. Now, how does HIV worsen TB? Well, if you have HIV, you get more TB. And not only do you get more TB, your latent TB, the chances of getting your latent TB activated are also more. And why is this? Because HIV affects those very cells which are responsible to be the defenses against TB. We all know that HIV kills the CD4 cells. Now, CD4 cells are the cells which are responsible for the CMI or the cell mediated immunity, which is the primary immunity which we have against TB. You have an infection which kills our TB soldiers, so of course the patient will get more TB. You get HIV, you get more new infections of TB, you get more recurrent TB, your reactivation of TB becomes more, and once you get TB, because of poor immune responses, it is more disseminated and often atypical. While on the TB side, what happens? We all know that TB causes systemic immune activation. So this systemic immune activation actually also accelerates HIV. And you get more viral load in people who have HIV and TB together. So hence the need for an HIV-TB collaboration, because we have now understood that HIV and TB need to be addressed together. A collaboration between the National TB and AIDS program is what is basically an HIV-TB collaboration. And it is nothing more than having efficient linkages or cross-referrals between the National TB Elimination Program and the National AIDS Control Program so that we can reduce the burden of the dual disease. Now we'll just talk about the HIV-TB guidelines. Ma'am, how much more time do I have?
Upasana, you have sufficient time, no issues.
Okay, ma'am, thank you. So now I talk about the HIV-TB guidelines. What is the current guidelines? Well, when it comes to the HIV-TB guidelines, we are talking about both TB treatment as well as TB prevention in people living with HIV. And TB prevention is there's a catchy phrase for TB prevention, which is called 3 I's. So these 3 I's are basically IC, ICF, IPT, and IC. So 3 I's of TB prevention in people living with HIV, and what this means, I'll tell you over the slides. So we have to understand that now HIV treatment and TB treatment for people living with HIV is through a single window service. What does a single window service means? That all HIV TB patients will receive their TB treatment from the ART center itself. They will use RNTCP mechanism for testing. They will use the RNTCP guidelines for diagnosing the patient, and also for all the definitions of RNTCP for declaring outcome and for labeling a diagnosis of TB. However, the ATT will be started, followed up, and outcomes will be declared at the ART center itself. So this is what we mean by a single window service of HIV and TB for people living with HIV. The main components of that are intensified case finding. What is intensified case finding? Means intensified TB case finding in people living with HIV, use of CBNAT, NAT, or TrueNAT for diagnosis of TB among PLHIV as a frontline test, use of daily regimens for all forms of TB that is seen in PLHIV, that is a drug-sensitive TB we are talking about, having some support for adherence, giving INH preventive therapy, emphasis on TB infection control in HIV settings, and giving early ART to all. So coming to the first point, the first I is intensified TB case finding. So intensified TB case finding, ICF in HIV clinics, what exactly does that mean? Well, intensified TB case finding is a type of active case finding where you don't wait for the patient to tell you that he is sick, but actually you ask the patient if he's sick and you go actively looking for TB disease in people who are coming to you in ART centers. And it involves three things. One is that you screen every person who has HIV and comes to the ART center at every visit with the 4 symptom screen. Secondly, if there is somebody who is seen to have a symptom, he's not asked to wait in lines, but is fast tracked to the medical officer of the ART for taking a decision of TB testing. Once the medical officer takes a decision for TB testing, then the patient gets the benefit of a rapid test, that is a NAT test, which is not only rapid, but also more sensitive and can pick up TB in cases where it might be missed by other tests. So when you complete these three, that is when you have done your intensified TB case file. And what are the goals of ICF? It's simply the fact that if we can diagnose TB cases early in people living with HIV and treat them promptly, then we can reduce the HIV-related TB mortality. And we can also, very importantly, prevent ongoing transmission from one PLHIV to the other and to his family, to people waiting in the waiting area. So these are the goals of having intensified case finding. We all are now familiar by this time what is the 4S symptom screen. For any current cough for HIV positives. For HIV positives, remember it is any current cough. There is no duration. Any fever, a history of weight loss or any current weight loss, night sweats. For children, it is poor weight gain or even weight loss and contact with the open case of TB. So these are our 4 symptom screening tools for children and adults. And how are they done at the ART center? At the ART center, any person living with HIV who attends the ART center, whether it is a new patient or a follow-up, at every visit is asked for these 4 symptoms by our community care coordinator. The community care coordinator is actually a paramedical staff who is not a medical graduate or even a nurse, but is a community worker. And his idea is that when he is most in touch with the people who come to the center, like he's the first point of reference. And if he doesn't ask for 4S, then there can be no question of fast tracking. So he asks for the 4S symptoms, and according to his understanding, he records the 4S symptoms. If any symptom is positive, then he immediately reports to the ART nurse, who, being a part of the medical team and being medically trained, is in a better position to thrash out whether the patient is actually 4S positive or not. So she again asks the 4S symptoms from the patient. Between the care coordinator and the nurse, certain patients are seen who actually are not 4S positive for various reasons. So she then thrashes out who is actually 4S positive and needs to be fast tracked to the medical officer. So this person who is found to be 4S positive by the nurse breaks the line and reaches the medical officer on priority, who again asks the 4S symptom. And then he takes a call whether this patient who is 4S positive needs to be investigated for TB, or is there some other alternate diagnosis which needs to be addressed first or needs to be managed, like a viral fever or an upper respiratory tract infection or a UTI, whatever reason he feels as a doctor that might be there for not getting a TB investigation done, that is done at the level of the doctor. But once the doctor decides that this 4S positive person needs to undergo a TB testing, immediately this algorithm is activated. So in this diagnostic algorithm for pulmonary TB, all people living with HIV, as you can see here where I'm pointing, as soon as they are cases of presumptive TB, that is, they have any of the four as positive, they are immediately asked to go for a CB-NAT, NAT or true NAT, and simultaneously also an X-ray is done for them. This is how ICF, intensified case finding, is strengthened for TB, HIV infective TB presenters, that we immediately send them for a CB-NAT and we simultaneously ask them for an X-ray. So how is a person referred for TB testing from the ART center? The medical officer says that, okay, this 4S positive needs TB testing. Now this 4S positive who needs TB testing is immediately sent to the ART nurse by our doctor. The ART nurse, she will refer for CB-NAT. She sends the patient to wherever the CB-NAT facility is, within the hospital, outside the hospital, in the district, as may be the case. She also simultaneously refers the patient for an X-ray, and she will now line list the person who has been sent for TB testing. So she has a record of every person who has been referred for a TB test from the ART center, so that she can retrieve the patient in case the patient is lost while being sent for investigations. This line list is also actually a digital line list, which is done by our data manager. But the point here is that it is a line list that is maintained. Now the patient will come back with a CB-NAT result and an X-ray result. And once these are available, this should happen within the next 2 to 3 days. The patient comes back to the senior medical officer of the ART center for further workup. Now, based on the CB-NAT or other lab reports, clinical investigations, or if any other reports are required to confirm an extrapulmonary tuberculosis, like probably an ultrasound of the abdomen, a lymph node aspirate, the medical officer will establish a diagnosis of TB, or will say that a TB is ruled out, depending upon what is the result of investigations. Now, once this patient is actually diagnosed as TB, the ART medical officer will categorize the patients of living with HIV as per the NTEP guidelines as microbiologically confirmed or clinically diagnosed, rifampicin sensitive, or rifampicin resistant or NAT. Now here there is a word. Suppose somebody comes to us who already has a sputum report and shows that it is sputum positive or sputum negative and they are HIV positive, we would still like them to go ahead with a NAT for two reasons. One, NAT is a more sensitive test, and we really need to pick up all these TBs. There is no scope of missing out TB diagnosis. And secondly, a NAT test will also tell us upfront about rifampicin resistance. So once the patient is categorized, all people who are found to have rifampicin sensitive TB are initiated on ATT at the ART center itself. So what is the ATT? It is the daily RHZE FDCs that we give to all patients of TB in the country. If it comes out to be R resistant, then please send the patient to the DTO or the PMDT site, where the patient can receive treatment for resistant TB and will also undergo further testing like the second line LPA, the extended culture. But now if we come back to a drug sensitive TB case, the medical officer sees that this patient is drug sensitive. He prescribes FDC. The patient now goes to the nurse. The nurse will make a treatment card, TB treatment card for this patient in duplicate. One is kept at the center and the other is given to the patient to tick daily as soon as he takes the drugs for the day. Sorry, this is wrong. Then she identifies a family DOTS provider. In HIV medicine, we always have relied on a family treatment guardian, a family treatment supporter who is counseled by our counselors, given education and counseling, and who is actually empowered to take the correct decisions for the patient at times when the patient himself might not be very adherent. So it is the sister's job to talk and the counselor's job to talk to the patient and his family, identify a DOTS provider. Then after a treatment card has been done, enter the patient in a HIV TB register. Now this patient from the TB line list, he comes to the TB register. Enter the patient in the TB register. Counseling has taken place. Now patient goes to the data manager, who gives him a NICSHE number and enters the patient's name and details of the NICSHE. Now, once all this is done, the counselor will lead the patient to our ART pharmacist, who will dispense the correct ATT. So now this is for somebody who we will immediately start ATT if we diagnose them as drug-sensitive TB or TB in which we do not know the resistance pattern. But once we have started the patient who has who is drug sensitive / drug unknown, we would want the patient, if he is not positive for MTB showing RIF sensitivity, to start ATT at the ART center immediately, but we do not forget to send a sample for first line LPA, because it is very possible that the patient could be RIF sensitive but INH resistant. So if the patient, a RIF sensitive patient who's already on ATT RNZE, which was started immediately, is found to have INH resistance on first line LPA, then again the patient is referred back to the DRTB center or the DTO. If the patient comes out to be INH sensitive, or if the LPA is not possible because there is no growth in the culture or the sputum, then we will continue the first line ATT at the ART center as we had originally evaluated. In case NAT is negative or not feasible, then we will evaluate for TB using appropriate diagnostic tools. And a negative NAT, remember, does not rule out TB. So if TB is diagnosed despite a negative NAT, then also we will start ATT at the ART center. And in case TB is ruled out, we will evaluate for alternate diagnosis till the patient becomes asymptomatic. Now, what would be the ATT for drug-sensitive TB cases in people living with HIV? Antitubercular treatment remains the same as in non-HIV, the FDCs. For all new and previously treated cases, 2-HRZE given 7 days a week for 2 months, then 4-HRE given for 7 days for 4 months. Tablet pyridoxine 10 milligram daily is sort of a very good co-prescription with ATT in people living with HIV, because people living with HIV are slightly more prone to peripheral neuropathy. And directly observed therapy is strongly observed for all HIV TB cases, and this has to be ensured by the ART center by actually fixing a very good treatment regimen. The only place where the ATT is different in people living with HIV is when there is a patient of HIV on second-line antiretroviral therapy, which has one of its components as a protease inhibitor. In case of a protease inhibitor, it is not possible to give rifampicin, so instead we give rifabutin. The dose of rifabutin with a protease inhibitor is 150 milligram once a day daily. Now, how do you treatment support and expect adherence to ATT when you dispense ATT from the ART center? Well, the only way we can ensure an adherence, and we actually work very hard at it in the HIV clinic, is initial treatment adherence counseling by our counselor. ART centers always have trained counselors who are well trained in giving adherence counseling. Adherence counseling is actually a different package of counseling with a different way of doing it, and we have been doing it since the beginning for ART. Now we do the same counseling when we initiate a patient or ATT. We will make a treatment supporter out of one of the family member. So we will give DOT through a trained treatment supporter who will observe the patient getting treatment every day. The other way we sort of try to ensure adherence is that we request the patient to bring back empty drug packets and their copy of the treatment card on every visit. So this is about ATT in patients with HIV. Now coming to another very important aspect of HIV TB management, that is management of the HIV disease. We have to remember that all HIV patients who are diagnosed with active TB, we have to start ART irrespective of CD4 count. However, when you give ATT and ART together, there are some considerations that they are drug interactions. Rifampicin cannot be given with PIs and some NNRTIs. Similarly, there are overlapping side effects. There are certain side effects which are of ATT as well as ART also. And of course, there is more pill burden. Now, we know that ATT is essential. We know ART is essential and they have to be given together. So when we have to start two regimens and there are certain considerations, they need to be spaced. And sometimes not only spacing is not enough. You also have to modify your ART regimen, as you will see in the next slide. So coming to spacing, if a patient with active TB is diagnosed with HIV and requires ART, the first priority stays to start TB treatment. You have to start ART because you cannot expect any mortality benefit if you do not start ART soon in a patient of HIV TB. But for ART, you cannot compromise your TB treatment. So first priority is TB treatment and start ART as soon as ATT is tolerated within 2 weeks to 2 months. One exception of starting ART as soon as possible is CNS TB, in which we expect to start ART about approximately 4 weeks of starting ATT. The reason for delaying, I would not say delaying, for withholding. Should I continue?
Yeah, we are just taking care of that technical
Okay.
issue. Yeah, it's done.
So the reason for withholding ART in patients with CNS TB is that it has been seen at times, not at times, actually many times, that patients with CNS TB, if the duration between starting ATT and ART is very small, then they sometimes get life-threatening immune paradoxical reactions. So, except for the exception of CNS TB, in all cases of HIV TB, after starting ATT first, please try to start ART as soon as possible. And hence, it means that you need to refer a patient of HIV with TB or ATT to an ART center as soon as possible, because the ART center also needs some time for workup. What is the ART regimen of choice with the first line anti-TB treatment, the RHZE? It is tenofovir plus lamivudine plus DTG, which is commonly known as PLD. But because of the drug-drug interaction with rifampicin, we have to give an extra dose of DTG 50 milligram till the time the patient is on a rifampicin containing ATT. So the ART regimen of choice is DTG. However, because of this drug-drug interaction, we have to modify ART. So here is the second point of, like I said, that when we give ART and ATT together, we need to space them, as well as we might have to modify our ART. And in one instance, I have already told you that we have to modify our ATT when we are giving it with a protease inhibitor containing ART, because we do not have a better choice than protease inhibitor for a second and third line ART. Coming to the regimen of ART when you give it with DRTB treatment, the good news is that the first line tenofovir, lamivudine, dolutegravir, the TLD regimen is also safe with bedaquiline containing drug-resistant TB regimen. Sorry, this is a typo. And there is no need to give an additional DTG because there is no rifampicin in this regimen. And DTG is safe with almost all of our second line anti-tubercular therapy drugs, except sometimes you might have to give dolutegravir has certain CNS side effects. So sometimes with cycloserine high dose INH, if and only if you see CNS toxicity in that patient, we have to remember not all side effects occur in all patients. If you see CNS toxicity, then you might have to replace DTG with nevirapine. So this is just an overview to make you understand how anti-TB drugs are there under NACO. Like you all have first line, second line anti-TB drugs. You have ABC anti-TB drugs. Similarly, we have first line anti-TB regimens. We have second line anti-TB regimens. And we have third line anti-TB regimens. But as you can see, as we go down the table, the options become very less. So this is one of the problem we have of ART as of now. Now coming to the concept of co-trimoxazole preventive therapy. Co-trimoxazole preventive therapy is an adjuvant therapy that is given to people who have HIV and who have TB also, because it substantially reduces the mortality in HIV TB patients. What is the exact mode of activity? It is not clear. Please remember, this is not a TB preventive therapy. It is something that is given as an adjuvant therapy in HIV TB patients because it's seen to reduce mortality. And it is also given to people living with HIV who do not have TB but who have CD4s less than 350 for the same reason, that it can bring down all recent mortality. The reason is because it prevents a range of bacterial infections in general in HIV TB. Like it brings down your chances of malaria, it brings down your chances of community acquired pneumonia, it brings down your chances of having septicemia. So probably there is a wider benefit of co-trimoxazole adjuvant therapy, and it is basically tablet Septron or co-trimoxazole double strength, 1 tab daily, given in all HIV TB patients, initiated as soon as TB is diagnosed or CD4 falls less than 350, and given throughout the anti-TB treatment or to a patient who has less than 350 till he increases his CD4 to more than 350 on 2 separate occasions. So this was about TB treatment, about HIV treatment, and now coming to INH preventive therapy, the second I of TB prevention. Well, these are some studies from Brazil, South Africa, and Botswana, which basically show that if you give TB prevention in people with HIV and do not give ART, then the protection is there, but it is only to the tune of 65%. If you give ART alone in HIV TB patients, then also protection against TB is there. But then again, also it is about 67-64%. But the minute you combine ART with IPT, the protection can actually reach levels of 89 to 97%. So this makes a strong case of TB prevention in people with HIV. And currently, even though we have the 3HP regimen, which has been approved for people with HIV, for logistic reasons and programmatic reasons, we are still not giving 3HP in people living with HIV. And currently, all ART centers are continue to give IPT. Again, how is IPT done? Again, the reason, again, in an ART center, as I told you, every patient who comes to us is screened with 4S. Now, as I said, 4S positive are tracked. There are also a substantial number of people who are 4S negative. So the 4S negative people, what are they done? If they have not received any TB preventive therapy in the past, then we will assess them for IPT. That is basically, we will see, do they have any contraindication to IPT? Like, do they have hepatic failure? Do they have peripheral neuropathy? Are they allergic to any component of, like, are they allergic to INH? So basic things we will assess for contraindication. And if there is no contraindication and the patient has not received TPT in the past, we will give him a full dose of IPT. And the IPT that is given, the regimen, is for adults and children more than 12 months living with HIV, in whom TB has been ruled out. So the eligible people are all adults and children more than 12 months living with HIV. IPT is recommended for 4S negative HIV cases, even if they have been treated for TB in the past. If somebody has a past history of TB and they are PLHIV and they are 4S negative and they have not had IPT in the past, then IPT is recommended. So what is this? This is basically secondary prophylaxis. If you have already had TB and then you're talking about prevention, it is secondary prophylaxis. Similarly, if suppose there is an HIV TB case with active TB currently on ATT, then as soon as the patient completes his dose of ATT, from the very next day, he is given a 6 months course of IPT from the day of last dose of ATT. So this again is secondary prophylaxis. So IPT is given in people living with HIV as both primary prophylaxis, that is given to 4S negative people who have never had TB, and also to people who have had TB and who are completing treatment of active TB. This is the regimen for adults, 300 milligram with 50 milligram of vitamin B6. For children above 12 months, isoniazid 10 milligram and paradoxin 25 milligram, both given for 6 months. There is a recent recommendation which says that children more than 10 years can be given doses as per the adults, but it is still not a part of the NACO guidelines. Therefore, I have not noted it down here. And please remember, INH preventive therapy is not given for prevention of DRTB, either primary or secondary. Coming to the last I is infection control. So talking about infection control at ART centers or airborne infection control or prevention, TB infection control at ART centers. Now this is a topic in itself, but I think it would suffice to say that while there are managerial activities in place at the national, state and hospital level, at the ART center level, sorry, administrative controls are very important. Administrative controls are simple measures like providing masks to the coffers in the waiting area, separating coffers and known open cases of PTB in about 6 feet segregation from other patients, fast tracking coffers and TB patients through the system so that they do not stay for a very long time in the waiting area, and educating people on cough hygiene that in case they need to cough, they should cough inside a cloth or inside their elbows. And if there is any visible respiratory secretion on their hands, they should go to the restroom and wash their hands with soap and water. There are certain environmental controls also which can be done at the ART center. That is, you can maximize your natural ventilation, open all doors and windows, have mixed mode ventilation, have strategically placed fans or a lot of fans, have exhaust fans so that you can maximize air exchanges. And of course, COVID has taught us that we could use personal protective equipment. To summarize, well, TB in PLHIV is managed at the ART centers themselves. That is the single window approach. HIV-TB collaboration is TB treatment and prevention, both TB treatment and prevention in people living with HIV. Intensified TB case finding is symptom screening, fast tracking, and rapid TB testing of TB symptomatics. Once a patient is diagnosed TB, you start ATD first. Promptly, it is the priority at the ART center itself. ATT would be same as an HIV negative, except prescription of rifabutine instead of rifampicin with protease inhibitors. ART in HIV-TB cases is absolutely essential if you want to prevent mortality. All HIV-TB cases are eligible for ART and it is to be initiated as soon as ATT is tolerated. You cannot delay ART. TLD, tenofovir, lamivudine, dolutegavir with an extra dose of dolutegavir 50 milligram is the first line ART regimen of choice with rifampicin containing first line anti-TB regimens. TB preventive therapy should be offered to all eligible people living with HIV in whom TB has been ruled out through the 4S symptoms complex. Well, thank you. That's all about HIV-TB guidelines in a nutshell. And now I pass back the mic to the moderator.
Dr. Upasana, it was an excellent presentation and so many concepts have been cleared. So now I'll open the forum for discussion. And just before discussion, I would like to inform that there is a post-test which will come to your mail. Please attempt it. The certificates will be issued only to the participants who will attempt the post-test and will be able to get at least 50% marks in their post-test. In the last session, we had about 75 people who attended the session, of whom 33 attempted the post-test and all 33 got above the qualifying marks and they have been issued the certificates. So now I open the forum for discussion. Any question, query that you have, you may ask the expert.
Dr. Upasana, this is Dr. Hitesh Verma as STO Haryana. I have two questions, ma'am. Hello, am I audible?
Yes, sir.
Ma'am, first thing, from where are you getting the pyridoxine, from the NTP program or from the AIDS program?
We actually get it from the AIDS program. The NTP doesn't give it. NTP used to give it to us initially, but then something happened. Then our Delhi State AIDS Control, like HIV is managed to state AIDS control organizations. So we are getting it from the state AIDS control organization.
Yes, ma'am. Secondly, when we wanted to start a dot center at our HIV counseling centers, counseling and ICTC centers, there was a strong objection that since people come with the PLHIV people come, they may get TB from TB affected people. So the same thing is actually happening in our ART centers. The TB patients are coming, you are giving them ATT, which is actually a good thing since they'll be able to get both the medicines together. Is it feasible for us to start a dot center in ICTCs also?
Actually,
Is there any objection to that?
uh, actually, doctor, that is a very good question. And when we were building our new ART center, we were also faced with this dilemma. So what we did was, because now in ICTC, all TB patients have to go to ICTC for HIV testing. That is a guideline. So TB patients will be visiting ICTC as it is. So actually, if you look at it in a very broad way, there is actually no reason to object, because all TB patients have to come to ICTC for getting it tested. And the number of patients who are HIV positive in an ART center, probably 10%, 15% of all attendees. So for an ART center to take care of other TB patients other than HIV is not correct, because we cannot have all TB patients coming in for us, because we have to maintain some level of infection control. But probably the same doesn't the same guidelines would not be there for ICTC, and of course the ICTC people will have to take in cognizance a lot about infection control.
Ma'am, there's another one thing about TB. It's quite some time anybody has asked me for rifabutin. So how do you change a regimen from first line ART to second line ART? Do you do some test or you wait for
By
some?
viral load. By viral load. We have HIV viral load. If the HIV viral load is more than 1,000, then we have a method in which we detect whether it is non-compliance. Like we will counsel the patient, test their viral again. If it again shows treatment failure, ART treatment failure, then the patient will be shifted on second line ART.
Okay, you wait for some time on first line ART,
Yeah.
and even
Yeah.
then the viral load remains more than 1,000. Then
Yeah.
you
Yes.
start on
And that's a big challenge. Actually, that's a big challenge, because with the FDC, these are big challenges. In FDC, it is very difficult to take out the rifampicin from the regimen. So even if we can manage a rifabutin, which we are usually managing from our centers of excellence for HIV, they have certain discretionary funds for opportunistic infection treatment. So all patients who have second line ART on second line ART and also have drug sensitive TB. So now they need a rifabutin. We send them to our center of excellence, where out of their discretionary funds, they will buy a separate ATT and they will buy a rifabutin for this.
Is there any center of excellence in Haryana?
I think you are linked to the Maulana Azad Medical College Center of Excellence in Delhi.
Yeah. That,
Yeah,
in
there
Delhi,
is a separate one there.
yeah, exactly. But I don't remember sending any patient, any district sending any patient.
So that's fortunate. That means you never needed a second line ART and TB first line TB.
That means we needed the training more than anybody else.
Thank you for saying that.
Thank you, ma'am. Thank you very much, ma'am.
Thank you very much for your involvement.
Thank you, sir, and thank you, Dr. Upasana. Any other question? Dr. Upasana, they use what is the status of 99 dots? Is it still there? What is it?
No, ma'am, it's not working at all. Frankly speaking, it worked just for a few months. First, there was one glitch, then another glitch, then another glitch. And when it worked beautifully. But the problem was it wasn't a very robust and stable software. So we don't have 99 dots at all. Now, as I said, we are no longer relying on 99 dots. We are just relying on counseling, checking up with the family dots member. And third is asking them to bring back the second treatment card, which invariably, frankly speaking, from the field, which invariably comes back blank, and asking them to bring the empty blister packs.
So what I wanted to know was that is it still part of the program or?
No, it isn't. No, it isn't, ma'am.
Okay. So any other questions?
Ma'am, just to add to what Dr. had just asked me, there are several places where there are ICTCs in dot centers. Probably their ICTC staff is protesting because they are not used to the concept of both of them being together. But Delhi mein there are so many dot centers where there is an adjoining ICTC.
Okay. Are there any other questions? We have sent the post test on your mail. Please attempt it. Okay.
So Dr. Upasana, one for the benefit of everyone, how sensitive is this 4S symptom screening?
Sir, if we look at the literature, of course, they say it has a very good negative predictive value. So in our experience, and we had also actually done our research on this 4S symptom with Dr. Padma way back in 2010. So we had also found it as a very good rule out tool. Like anybody who is 4S negative, the chances of TB are very, very, very minuscule. But the problem is that it is not a very specific tool. So a lot of people get gathered into the net. So it becomes a huge problem to understand who to send for TB testing, who not to send for TB testing, which again becomes, frankly speaking, counterproductive. If you have too many suspects, then also it becomes counterproductive. But in the absence of a better tool, I think this is what's continuing.
Even for EPTB cases, like this has always been a question, okay, pulmonary TB agreed, but what about the EPTB cases? Is it equally sensitive or?
Sir, the components of fever and weight loss and night sweats are very effective for EPD.
Okay, thank you.
Ma'am, can we have the same question on the other way? How many of the 4 symptom complex positive had TB?
So I don't know that, but it is, as once again I'm saying, so a lot of patients, just like there's a huge lot of patients who come to the nurse for fast tracking. I think 4S positive, how many would we have? We actually diagnose about 5-6 patients in a clinic like ours from the 4S symptom complex. I think 20%. And we are also doing a student thesis in which we are trying to find out with Dr. Singla's, one of Dr. Singla's student, we are trying to find out actually how many 4S positive effectively translate into a TB diagnosis. So I don't have the answer yet.
So we request our DTOs to ask some questions. We don't want it to be a one-way communication. This clinic is for you. So we would request that you come up with your queries, questions. Dr. Upasana has a vast field experience where she can really guide us onto TB HIV. So any questions are welcome.
And they can write email, मेरी email दे दीजिएगा if बाद में किसी को कोई doubt आता है तो I'll be happy to answer.
Sure. We will share it on the chat. Since there are no questions coming, can I request STO Haryana sir, Dr. Hitesh, to give his closing remarks, because sir, this clinic we are specially doing for Haryana. So your comments are very important to us.
Thank you very much, ma'am. This has been such a wonderful session, and next time we'll have a little bit more presence. We'll include the HIV people in the part of in these sessions also. So thank you very much, ma'am.
Our pleasure, sir. So we will again come back with the new speaker next time, new expert with topics. And you can always suggest us the topics that you want us, because it is for your state. So if the topics come from you, it will be more helpful for us to organize them as to what is your need. So I think I'll coordinate with you, sir, as to what topics we should keep. And
Surely, ma'am. Surely.
So next time again we'll have. And I think Nitin has, yes, he has given you an email ID where you can, anyone can write us any comments, suggestions, or anything. And
Ma'am, can I say something, please?
sure, Dr. Upasana.
Yeah, so I would like to invite everybody. We are having an HIV conference with collaboration with the HIV division of Henry Ford Hospital on 8th and 9th of January at NITRD. So we would like all of the people here, we invite them, and as soon as we have a website going, I will send a personal invite to everyone with a link to the website, and we would really be honored if they would come and join us.
Great.
Thank you.
Thank
Surely,
you.
ma'am, you'll find the details and all the some of the counselors and ART centers to be there in your conference.
Thank you so much. I will definitely send that, and it will be a very fruitful discussion because we will be talking a lot of science that is there but still not being done by us. So it will be like a orientation to other things in HIV
Ma'am,
science.
there's just one last question, if you can have me. In viral load testing, you are having it done in a closed system. Is that right now?
Yes.
Why can't we do it in an open system?
By open, you mean the kits of somebody else and the machine of somebody else?
Yeah, we have now in COVID, we have upgraded our infrastructure. We have a lot of RT-PCR machines. Around all 22 districts of Haryana have their own RT-PCR machines. We are already doing quantification tests for hepatitis B and C.
Oh, wow. But you
Open
can
kits.
आप अपनी HIV कर सकते हैं RT-PCR में, but it will be very expensive for you. One test will cost a lot of money.
Exactly how much? We are already paying a lot.
I actually don't know. I'll have to ask somebody in the lab. मेरे को ना bulk purchase पे कितने का पड़ता है ये नहीं पता चलता. I don't know that. I know कि in the market it costs about 3,000 rupees to get it done from the market.
But it will cost much less on an open RT-PCR. Can you have us tied with someone who
I will.
has more technical know-how on this? We can have.
I will actually send the lab person in NACO who takes care of the viral loads there. And probably they could make you a viral load center. So then the kits can come from there. You might not need to pay for the kits.
Ji, ma'am. Exactly, ma'am.
Yeah. We can try to start this dialogue.
Ji. Because already we have such a huge setup, we need to have use for them also.
Yeah, absolutely.
Manpower we have, machines we have.
Machine is the same, it is just a difference of the kits.
Yeah.
HIV का किट लगा दो वायरल लोड आ जाएगा, HCV का लगा दो HCV का वायरल लोड आ जाएगा,
Exactly.
HPV का लगा दो HPV का वायरल लोड आ जाएगा.
Exactly.
So I will try to hook you up with someone.
Exactly. Thank you, ma'am. Thank you, ma'am.
Thank you, Dr. Upasana, and thank you, Dr. Hitesh. And I have shared the contact details of Dr. Upasana with you. So I hope your state gets some benefit out of this clinic. So
Ma'am, there's another favor I want to ask of you. Can I join you and Nitin in our state group? Because you are sending it in another group, then I'll have to send it into my state group. I'll just join you in the state WhatsApp group. If it's okay with you.
yeah, it's fine, sir.
Thank you, ma'am. Everybody will have the information firsthand and directly.
Right, sir.
Thank you, ma'am. Thank you.
So thank you, everyone, and thanks a lot for attending today's clinic. Thank you, Dr. Upasana, for an excellent presentation.
Thank you for having me, ma'am. Thank you, sir, for moderating the clinic.
Yeah, so thank you, and we close the clinic now. Please take the post-it so we can issue you the certificate. So try to take the post-test till by 4 p.m. today. Thank you.